As a human being, the hardest thing to do is to change your habits. It's like we're so ingrained in the way that we live. Ozempic's like biologically doing the opposite thing of what we would expect for weight loss. But the reason we get the weight loss is because the impact on the neurons in the brain.
Leptin is a hormone that's released from fat tissue. And the idea of leptin is that it inhibits the need to feed because it's an indicator of how much energy you've got in reserve. If we're reducing the level of fat, leptin will also reduce.
When we look at like the long-term effects of those things, you know, you're getting testicular atrophy, your infertility rates go up massively, and some guys smash it so hard that we can't like re-establish.
It's definitely a risk benefit that needs to be weighed up between the patient and the prescriber. And I think that it's really important that we try to educate patients on the right nutrition, the right diet, the right exercise regimes, so that they can use that alongside it and actually make lasting changes when they do end up coming off the medication.
If we're trying to fix something, they go, oh, just take that med and it'll solve all my problems. Hello and welcome back to the Helfy Podcast, and today we're going to talk about Ozempic and how it works in the body, go through some of the side effects and also what you need to do and what you can do. My name is Dr. Edward Lynch. I'm the founder of Helfy and the Wellbeing Doctors and also medical and lifestyle doctor. Today I'm really pleased to have on two incredible guests. They run the Chemical Couple Podcast. We've got Lee and Jess. Without further ado, Jess, what is the Chemical Couple Podcast?
Yeah, so we are both clinical pharmacists, and like you say, we have a podcast called the Chemist Couple Podcast.
Chemist, I got it wrong.
Couple.
Sorry.
Yeah, no, don't worry.
There you go.
But yeah, so we set it up just over a year ago, didn't we? And we just talk a lot about health, preventative health being the main subject matter of the podcast because we are advocates for that. We see every single day the impact of poor lifestyle, diet, exercise that it has on health. And so we just wanted to sort of set up a platform so that patients and also health professionals had access to scientific advice so that they could implement it into either the patient's lives or their lives. So yeah.
Nice. I think that's a big thing though, isn't it? Even you get loads of teaching around pharmacology in med school, but it's nowhere near in depth enough because we give out so many different types of meds and it's such a complicated area. It's like, how do they all interplay? And thankfully, we've got pharmacists who know a lot more than we do. But yeah, Lee, can you talk us through Ozempic and how it actually works in the body? Or rather, semaglutide, because Ozempic's just one of the brands. But
I mean, the main ways it works is within the feeding centre, within the hypothalamus. So there is a neuron called AGRP, which is a gouty or a gouty related peptide. And that is one, when it's stimulated, that we sort of look for feeding behaviours. So GLP-1 directly inhibits this. So then by doing so, it reduces your general energy consumption.
Okay. So GLP-1s, they are semaglutide meds.
Yeah. And
they're worked on this neuron in your brain to reduce your appetite, basically.
Yeah. Another way is that it delays gastric emptying. So another mechanism is if you release contents from your stomach, you've got more capacity. So we're doing the inverse. So we're making sure that food's staying in your stomach for longer, so then you're not going to have that need to feed.
Okay. What about sugar? Because it's indicated for diabetics. How is that working?
So GLP-1 is an actual naturally occurring hormone within the body. Normally has a half-life of 1 to 2 minutes. So with GLP-1 medication, we enhance that to 5 to 7 days. That's why it's so effective. But in natural physiology, it's called the incretin effect. So when you eat sugar through an oral route, it then stimulates this GLP-1 and the stimulation of insulin, which would then allow the body to sort of allocate the sugar towards the cells to prevent hyperglycemia.
Yeah.
So that's why it works in diabetes so well.
From an energy perspective,
okay,
what are your thoughts?
In terms of,
if it's increasing the amount of sugar we're putting inside the cells, that's the opposite effect of what we want for weight loss.
It is. I think its effects on diabetes mainly come through the actual effects of weight loss and fat loss, because there's a theory from 2008, the twin cycle theory, where diabetes is induced by type 2 via this influx of fat within the liver and pancreas, which then causes insulin dysregulation from the pancreatic beta cells. So I think by reducing energy consumption, it's allowing a normal physiology to restore, and it's not directly putting sugar into the cells that's beneficial.
Yeah. What do you mean by beta cells in the pancreas?
So these are the ones that stimulate the insulin release. Well, these are actually what creates insulin and release it within the vasculature anyway.
Yeah. So that's the opposite of the alpha cells, almost.
Yes, yeah.
Can we go into that, just so we understand the difference between...
We can. So alpha cells, from memory, release glucagon,
Yeah.
which is the opposing hormone to insulin. So in the fasted state, your blood glucose levels will tend to drop. So then glucagon is stimulated from the pancreas, and then that causes glycogen to break down within the liver and allow a steady state of blood glucose, which prevents you from going into comas and gives basically your nervous system an energy supply.
Nice. Great. But then Ozempic, it's working on both of those mechanisms in a way, because it's increasing. When we say Ozempic, everyone talks about weight loss drugs being Ozempic, but there are others. But it's increasing the insulin. So it's stimulating the beta cells to release more insulin, driving more energy into the cells. So we're taking sugar out of the blood and putting it into cells, and we're storing it as energy, which is not necessarily what we want. But then it's also decreasing the amount of glucagon. So we're also decreasing the amount of breakdown of glycogen into glucose. So if your body's needing to use, it needs energy, normally we would break that down from cells and taking the energy out of the cells into the blood to be utilised.
Yeah.
So Ozempic's like biologically doing the opposite thing of what we would expect for weight loss. But the reason we get the weight loss is because the impact on the neurons in the brain.
It is, but also insulin also acts in a similar way to GLP-1 on them neurons. So it will inhibit the AGRP1, which I said earlier, which stimulates feeding. And that's because the body's signaling that it's in a fed state.
Yeah.
So you've probably got the secondary effects of insulin going that way. But yeah, in terms of its overall process, it just doesn't make sense that we are harbouring energy.
Yeah. So we've got Ozempic, Wegovy, they are semaglutide.
Yeah.
And then there's also now, which is flying off the shelves, Mounjaro. Can we go into Mounjaro and why it's different?
We can. Do you want to touch upon that?
Yeah, I can do. So Mounjaro is actually a dual agonist of GLP-1 and then also GIP, which we actually don't know too much about GIP, to be honest, but I think it works on the same receptor site as GLP-1. And the difference being is that GIP is has a half-life of around 7 minutes naturally. But obviously, again, we increase that to around 7 days within Mounjaro. So yeah, with it being a dual agonist, it just means that you're getting the effect of GLP-1 and GIP doubly. So it's effects potentiate. And then also you were saying that it acts on this agouti-related peptide, or somewhere in the nausea centre in the brain, actually, you were saying. The
nausea centre, yeah.
Where it decreases the side effects that come with these medications. So we know that from GLP-1s, the main side effects are nausea, vomiting, which actually can be quite debilitating for patients. And just from experience, some patients just don't tolerate it. So we'll put them on it and the side effects are that bad that they can't tolerate it and they have to come off it. Whereas, like I say, with the new medication, Mounjaro, that side effect profile isn't as bad. And so patients do tend to tolerate it a lot better.
So you've touched on the side effects there. If I'm on Ozempic, or let's leave Mounjaro to the side for a second, but say if I'm on Ozempic, what kind of side effects can I expect?
So like I just said, the nausea and vomiting being they're the main ones. You can get things like diarrhea and constipation. I think it massively depends on you as an individual, whether you get either or. And then the main side effect, which we always have to counsel a patient on, is an increased risk of pancreatitis. So I think you said earlier on that it was a 3 times increased risk if you're taking these medications. You would know about that. It's usually a very sharp pain within like the centre of your stomach, isn't it? Where it'll go through to your back. It's excruciating. But if you actually do, end up getting that, you have to stop the medication, and I think it's contraindicated to ever be on a GLP-1 in the future after that. But apart from that, really, they're quite well tolerated medications. I can't think of any other sort of, a dehydration may be one of them, but that's not due to the actual medication. It's due to the fact that you've not eating as much or drinking as much because you don't feel like you want to. So I think that's just one thing to bear in mind, is that making sure you're hydrated when you're on the medications. But can you think of any? I
mean, one that a lot of people complain about is sulfur burps. And it makes sense because the food staying in the stomach for longer, so it's going to lead to, it's a fancy word, eructation, I think.
Right.
Yeah, I looked at that before.
Okay, nice. The things I've seen as well is around the actual fat loss component itself. It's not just fat that we're losing. We're losing a huge amount of skeletal muscle as well. So in terms of aging and aging well, like sarcopenia is a massive issue where people are just losing muscle tissue naturally as they age. But there's very simple things that we can do to actually maintain muscle mass, which is get enough protein in your diet and continue to strength train. Essentially, resistance exercise can like maintain muscle tissue. But I think it's around a third of weight loss that's coming from semaglutide, Ozempic, Wegovy, is actually muscle mass that we're losing.
Yeah.
It's like, we don't want that.
Yeah.
No, but if you look at the patient cohorts that tend to use them, they've been inactive and then they're going to a complete energy deficit. So they've never been resistance training. So it is understandable how it's happening.
Yeah, definitely. But then I think with the patients that are doing it as well, the rebound rate is huge. So I think, as with almost all meds that are given, it's like a quick fix, isn't it? People are like, oh, I want to take this thing because it's going to help me get X without having to put loads of effort in. And we know when we look at patients, the hardest thing, well, as a human being, the hardest thing to do is to change your habits. It's like we're so ingrained in the way that we live. And if you say, well, here's a fitness plan and a nutrition plan, what's the adherence to that thing like? So they go, fuck it, I'll just get on the semaglutide. I'll lose a ton of weight. But then they take the med and then afterwards, no habits have changed. Can we go into the pharmacology of that a little bit and what impact that potentially has on leptin and ghrelin and why that rebound rate happens? Okay, so like with semaglutide, which is Ozempic or Wegovy, if I'm taking that and then I come off it, like what we're seeing in patients all the time is that the rebound rate is absolutely massive. So they come off that drug and then they just pile the weight back on. And I think, from my limited knowledge of it, is that the patients, they want like a quick fix, don't they? If we're trying to fix something, they go, oh, I'll just take that med and it'll solve all my problems, and we don't want to put like the effort in to actually change our behaviours. And I think like that's always the hardest thing, isn't it? Whenever you're trying to make a change in your life, it's the actual habits. Like it's super hard to change habits. You know, it's just a hard grind if you're having to change your fitness and your nutrition, and there's probably other things in that like routine and going shopping and meal prepping. It's proper hard grind. So they go, oh, you know what, fuck it, I'll just get on the semaglutide. I'll lose a load of weight. But then we are seeing those patients rebound, and it's interesting to think about like what effect is that having on ghrelin and leptin, and what is the physiology behind that. But can you go into like pharmacologically why that rebound rate is happening?
I mean, if you look back through diets in general, people tend to lose a lot of weight through drastic dieting and then they put it back on. So it's not just related to the pharmacology, but the pharmacology exacerbates it because it's so much more effective. And in terms of leptin, it's a hormone that's released by adipose tissue, and it's a negative feedback for you to feed because it's an indicator of what your fat reserves are like. Higher leptin indicates high levels of fat. So if we're reducing the level of fat, leptin will also reduce. And if you've not changed your habits, like you said, because it's so much easier to take an injection, not even once a day now, it's once a week, so 4 times a month. When you stop taking that medication, which you've solely relied upon, then you are more than likely going to have a rebound because leptin will be such a strong stimulus at that point.
Yeah, it's interesting. The other thing I was thinking was, going back to the energy here, if you could control, I know the hardest part is like controlling your hunger, but in this hypothetical experiment, imagine you had 2 patient groups. One was on semaglutide or Mounjaro. They were on some kind of GLP-1, GIP receptor agonist. And then in the other group, they're not on anything, but they both eat and exercise the exact same. I do wonder which cohort would do better, because in the ones who are on Ozempic, for example, we've talked about the pharmacology behind of like what actually happens. So that they're putting energy back into the cells. But if we standardize exercise and nutrition in those 2 groups, they're on the exact same thing, or it's appropriate for their body mass. So we work out their total daily energy expenditure and we put them on like a 500 cal deficit, let's say, or even maintenance. Like however the research would be conducted, they're on the same thing for their body types. Which group would do better? Because I do think, from an energy perspective, the group who aren't on Ozempic surely would regulate their energy better if they're not pumping it all into the cells.
But I think the issue is that then they are, in terms of like, so GLP-1s do cause the release of insulin, but only in the presence of glucose. So if you're not eating, then you're not going to push any glucose into your cells because it isn't available to do that. So that's just a secondary sort of pathway that happens. But I think the issue is, and this is probably not backed by any science, it's just from personal experience with patients, they get this decrease in what we call food noise. So it's basically the need to feed or the thought of just constantly wanting to have food. So I think that may be another avenue as to how these medications work, is that they dampen down your need to want to have food. And so I know that you're saying that it would be the same amount of food and the same diet or the same exercise in both groups. But I think there are other ways that these medications work that we may find out over the next couple of years.
Yeah.
I think there was a study actually done in rats where they actually stimulated that neuron, which is the feeding centre, and it led to excessive eating, even if they've only just consumed food. And then the opposite,
kept on
eating. And then when
non-stop.
They've done the opposite way and silenced it, they actually ended up euthanizing the animal because it was just it lost a lot of weight in that time.
Just died.
So I think that's the potent thing there.
Yeah.
But in terms of studies, you're saying what would be the comparison? So when they run a lot of the studies, so for Wegovy, Mounjaro, whoever, they do have the control group, and I think they tend to lose about 2.4% on average of body weight from baseline, give or take over like a 50-week period. Whereas,
over 50 weeks, they've lost 2.4%?
Yeah, in the placebo group.
Okay.
Yeah, but in the treatment group, as we've evolved with these GLP-1s, it's now up to 22% for the treatment group, which is completely
huge.
Different, isn't it?
It is big.
And the jump from Ozempic or Wegovy to Mounjaro, it was 15% to 22%. So we're just getting better and better every time, and that's that dual activity.
Should we be taking them?
In the right cohort of patients, yes, I think they obviously are very effective medications, but I just think it comes down to the fact that a lot of patients are getting them privately. They're just getting them from a pharmacy and then with no follow-up. So we've looked online, haven't we, over the last couple of months, and you see patients or people on TikTok, and they'll set up their own groups with each other, and it's insane that they're giving each other, health advice. And I seen one patient who had stomach issues, and she was like, I've got stomach pain. So I was like, oh, it'll just be a bit of gastric reflux. And it's like, you're not medically trained in any way. How can you say that it is? What if it's not? But that's
it is dangerous though, isn't it?
It is, yeah.
I see. Well, I've seen one patient with panc secondary to I think it was Wegovy in A&E. It's not that many, but how many other clinicians are seeing?
Yeah.
Because your pancreatitis risk does go up by a factor of 3. But I just think long term, is there enough research that's been done to know the effect on? So the example I gave earlier was around like lads who go on to test cycles, to like compete with bodybuilding. Like they're completely messing with the hypothalamic pituitary gonadal axis, which is the control center for making testosterone from your gonads, your testicles, but also how your brain helps to regulate that. So then when we look at like the long-term effects of those things, you're getting testicular atrophy, your infertility rates go up massively, and some guys smash it so hard that we can't like re-establish proper functioning of the hypothalamus and the pituitary or the gonads. So I just think, is there enough research to be able to say that these medications are safe? I know they go onto short courses typically and we come off, but what is the long-term effect?
They have been around for a long time. Yeah. So I think they were first, the incretin, we found out about them in like the 1920s when we first isolated insulin. But the first GLP-1 agonist was around since 2005. So although not a lot of patients were on them, and they were only on them for type 2 diabetes, we obviously do have quite a lot of data surrounding long-term effects. I think the issue is that it's obviously now for a different indication, so it's for weight loss, and the amount of people who are on them. If you're going to give a large cohort of patients any medication, no matter what it is, you are going to start to see different things popping up. And so, yeah, I agree that we obviously need to be wary about what the long-term effects are, but like I say, in the right cohort of patients, if you are suffering with the effects of obesity, what's going to be more detrimental to your health in the long term? Is it going to be the effects of obesity, or is it going to be taking these medications that at the moment don't seem to have that many long-term effects that we know of? So it's definitely a risk-benefit that needs to be weighed up between the patient and the prescriber. And I think that it's really important that we try to educate patients on the right nutrition, the right diet, the right exercise regimes, so that they can use that alongside it and actually make lasting changes when they do end up coming off the medications.
Yeah. So the way to view Ozempic then is like a bridge.
Yeah.
It's something to help them get down to a healthy weight. But if you're taking it, you've got to be aggressive at sorting out your lifestyle as well, because otherwise we're just getting those rebounds.
Yeah.
So when is it clinically indicated? In what cohort of patients is it clinically indicated?
So type 2 diabetes is obviously the licensed indication, but in terms of weight loss, you've got a BMI of greater than 30, and then you've got a BMI greater than 27 if you've got a weight-related comorbidity, meaning you've got a BMI of 27 or more and you've got high blood pressure, high cholesterol, obstructive sleep apnea. They're the things.
Which is most of the UK population now.
Which is a lot of people now, yeah.
Yeah. Okay. That's helpful to know though, isn't it? Because I know a lot of people, it's the same with like, you see people getting aesthetic surgery done abroad. In a similar fashion, they're getting stuff done abroad because it's cheaper and they're coming home, and then we're getting loads of post-op complications. Yeah. I feel this privately prescribed Wegovy situation is similar in the sense that they go somewhere, they get it, they don't have appropriate follow-up, and we're getting a ton of complications afterwards, and they're like, what do we do?
Yeah, because I was going to talk about in terms of why it's not funded on the NHS. Because 26% of UK adults would be classed as obese, greater than 30, and then I think 48% are classed as overweight and obese. So you could be looking at least 33% being eligible for a drug that costs £180 a month.
Is there any age cut off?
I think it's not studied in elderly I did look at, so I think it was above the age of 85, where I don't know why.
That was only in one of them, and then the other one was 65.
Was it? Okay.
What about, do you have to be over 18? Or?
You are supposed to be, but I do know my friend's a dietitian and she works at Manchester Children's Hospital, and they do give under 18s, obviously under specialist supervision.
Yeah, I think it's actually licensed for 12 and above.
Is it?
Yeah.
Oh, I didn't know that.
No, I looked at it the other day.
Oh, okay.
12 and above.
Is that semaglutide?
I don't know whether that was Mounjaro or whether it was Wegovy. But it is. I mean, I used an analogy the other day in terms of should you use it. If weight is a detriment to your health in the next few months, by all means do it. But I liken it to a payday loan. So by all means, you take a payday loan out, it's going to sort your debts out that day, isn't it? But if you keep doing that every month, you're not getting to the root of the problem. Yeah. And that's the same with obesity. It's all okay offsetting it, but it's not going to change your health impacts in the future.
What about if I'm on semaglutide, I'm on a low dose, but I'm not responding to treatment? What would I do then?
What do you mean? Oh, go on.
So you're supposed to titrate the dose up to the maximum dose of any of these medications. It used to be that if you were not able to tolerate it, so if you had side effects from the drug, then the drug would be discontinued. I think recently they've changed that so that you basically just go into the dose that you can tolerate. So you can be, in terms of Mounjaro, the max dose is 15 milligram weekly. You could end up on 10, or you could end up on 7.5 milligrams. And if that dose is right for you and you're losing weight, then you are able to remain on it. But yeah.
Has the guideline changed because pharma want to sell more of it?
Well, I've noticed. So we originally started doing it for Saxenda, which is liraglutide, once daily, and it's a different regime. But in terms of if you couldn't tolerate the next dose increase for 2 weeks, you were meant to stop treatment.
Completely come off it?
Yeah, but when we look back at the wording now, it does say consider stopping treatment.
Okay.
So I think it has changed. And all the other indications as to when you can start it, they've also been broadened. In terms of, it says cardiovascular disease risk now as one of them, pre-diabetes, type 2 diabetes for weight management. That was never a thing.
It's interesting, isn't it?
So the answer to your question is, I've just completely skipped it, but you can read between the lines. I think there's more of a financial motivation there now,
Yeah. How much money are they making?
Oh, it must be a lot of money, like a lot. And I think you were looking at Eli Lilly, weren't you, in terms of like they're in the top 8 companies in the world for like profit. I think they make.
And they've got Mounjaro.
Yeah, they've got Mounjaro.
Yeah. I know they do other insulin products, but yeah.
I do think like so many people are on it. It's crazy, and also people are on it. I'm getting it from unlicensed ways or getting unlicensed preparations, from abroad. So in this country it only comes as a pen, which is probably important to actually tell the listeners, because people are getting them in vials and then having to reconstitute it themselves. That isn't a licensed product in this country, so it hasn't gone through the rigorous testing that all of the medication should do to be licensed in the UK.
What, are they self-administering that? Or are they getting...
Well, I was getting my hair done the other day, and the hairdresser was saying that one of her friends was getting someone to come round to the house to inject it for her. So I'm like, I don't know, it's pretty easy to inject a subcut injection anyway, so why someone's coming around to do it?
But it's the constitution, I think, because they might get the dilution wrong, or like sometimes, if it's like 4 milligram in a mil and you need X. I know a lot of people struggle with those drug calculations anyway. Like, what on earth are you doing that with no kind of medical experience? It baffles me. I hope the whole thing does become a lot more regulated, though, and I do hope that we kind of, if it's being done privately, that it is adhering to guidelines, because the guidelines are there for a reason. And it can we need to provide a lot more. You touched on this before. We need to provide a lot more like patient education on nutrition and exercise to actually start changing their behaviour, but it's not quick. I was going to say as well, but if you were to tell a patient nutrition advice, what would you say? We don't get taught it as health professionals in uni enough, so what are we supposed to tell them? I think it's only over the last couple of years that we've really looked into nutrition and exercise and trying to figure out what is the perfect diet, what is the perfect exercise regime. But before that, I wouldn't have had a clue when I come out of uni. I had a vague idea, but there was nothing that I could concretely say to a patient, this is definitely what you have to do. So I think that it's hard. There needs to be a lot of change within like preventative health. Was it you saying the other day, Lee, that people don't listen to NHS professionals often around like nutrition and exercise because they're one of the most unhealthy cohorts? So the whole culture is, it's hard because you're working nights, which makes you more predisposed to having like high carb, high fat, high energy foods. But also, like, if you look after somebody's relative, they're bringing in chocolates, know? So there's like just a constant access to chocolates and Cadbury Roses or whatever. And you see them all grazing all day on like ultra processed, low nutritional value foods. And I do think that's potentially why, if the GP is saying to you, you need to lose weight and you need to exercise, but they're a chunky monkey, you're not necessarily going to listen to them, are you? And I think that's why people listen to PTs a lot, even though some of that nutrition advice isn't quite there. I think you're right, medically, the education needs to improve at medical school for doctors, but also for pharmacists and also nurses. But there's also a culture issue where people in the NHS need to be healthier. But I think simple advice. Say it again.
No, I was just going to say, they're probably not going to listen to you, because if it's so compelling, the evidence of why you should maintain healthy habits, why is the practitioner not doing it? But I think a lot of it's changed due to ultra-processed food in general. And there is a study, if anyone wants to look into it, and I think it was run by someone called Kevin Hall, and he got 2 weeks of people eating ultra-processed food. And the theory is that you would be blind to ultra-processed food in comparison to whole food. And what I mean by that is, he got like an independent assessor to, let's say, make a Caesar salad, and then he'd done an ultra-processed version of it. So in terms of palatability, smell, whatever, it looked the same. And they said, well, there's your table of food. It's been pretty much matched for calories. You eat as much as you can for that time. You do 2 weeks on, have a flush period, and then do 2 weeks on a whole food diet. So you've, in theory, consumed the same amount of food, but by the end of it, the ultra-processed food group had 500 calories a day more.
Because they were
average.
Because the type of ingredients that are in it, just like...
They believe the ratio of fat to glucose to all the other things is so perfect that we can't recognise it quick enough. There's no...
But the companies making this food, they're literally trying so hard to make it like the perfect crunch, like the perfect amount of flavour. And it's like, it's just engineered. What does that book, that ultra-processed food book, he calls it edible substances or something. It's not actual food, it's like an edible thing. It's just mad that we're in this situation that people are eating such highly processed, low nutritional value foods. And touching on, when we look at like bloods, so if you order one of these blood tests, we can track if you're eating ultra processed foods, because you said, what tests can we do? Okay, there's over 15,000, but there's a couple in here which are tailored specifically around your nutrition. You're not getting those tests on the NHS, by the way. We're miles behind. Some of the tests we have to order in from like Norway to actually like check exactly where you are in terms of like your omegas, your arachidonic acid index and so on. But if you're having ultra processed foods, we can pick that up in terms of your high sensitivity inflammation. So it's bumping up really low levels of inflammation, but that chronically is not where we want to be at all. And I think people are they don't realise the impact it's having biochemically in their blood, because it's like, oh, just have a chocolate bar. But like, you do that, you can pick it up on one of these tests. Like, it's absolutely wild. But I think if you showed that to somebody, you know, if you gave them a drug and the heart rate went up to 200, they're going to feel it. But, you know, you can track it on monitors. I feel like with these kinds of things, like if people can actually see the impact the food is having before we end up at having diabetes, heart attacks, hypertension, raging obesity, obviously that, you know, you can see that one. But if we can try and bring that forward and say, look, the foods that you're eating here are having a huge impact on your blood work, let's try and stop that.
That's so important. The most common presentation for a heart attack is, well, for cardiovascular disease, is a heart attack, isn't it, in the night, I believe. So like you said, it happens 20, 30 years beforehand. And you were talking about CRP the other day. We have a cut-off of less than 4 or 5 in the UK. What would you say about 2 or 3 is still...
So in the NHS, I mean, it's crazy. Say if you're working on a ward, sometimes, like, people's... I mean, the amount of infections and things, so your CRP, it's a marker of inflammation or infection in the body. So it's C-reactive protein. If you've got an infection, your CRP goes up. There's other things that get affected as well, like your white cells, but your CRP goes up. Depending on how high it is, depends on... It's one of the variables that we use to work out how severely to go with antibiotics, let's say. But also inflammation is causing a rise in your CRP. So things that cause inflammation are things like stress, bad nutrition, not exercising, sleeping badly. They are pushing your CRP up. But we need to use something called high sensitivity CRP. So the NHS are testing your CRP, which starts at 4 and goes up into the hundreds. If your CRP is 100, that's very bad. Like, it's not the worst, but it's, you know, it's not good, and you probably need treatment. But if it's less than 4, the NHS just say it's less than 4, and it's helpful because you know somebody hasn't got like a raging pneumonia, or they haven't got like a really bad infection that will need treatment. But if your CRP chronically is at 2 to 3, that's quite like a high level of CRP, but it goes under the radar, completely under the radar in the NHS. And your GP will be like, oh yeah, you're fine. And people hear this all the time. It's like, well, I've still got symptoms, like I'm still experiencing symptoms. What is it? So I think the blood testing, all of the blood testing needs to be much more sensitive, and it needs to be a lot more preventative, because the NHS is kind of set up for, have you got disease? Have you got a problem now? Okay, let's get on top of it. They do some preventative stuff, but when we're looking at nutritional deficiencies, exercise problems, stress issues, even if you've got like IBS or endometriosis, like the actual types of testing that we're doing is a little bit different. So I think, unfortunately, it's getting bridged by the private world at the moment, which is, if you want this, if you actually want to look after yourself, you've got to go privately. So, I get it, because the NHS hasn't got the funding to back all of these different initiatives, and if somebody's generally healthy, there's somebody around the corner who's got cancer or is needing more urgent treatment, and there's only a limited pot of money. So I get why it doesn't get prioritised, but you're just constantly in this cycle. It's a double-edged sword, isn't it? If you don't get on top of it early, you keep adding people into the funnel at the top who've got cardiovascular problems, gonna have strokes, got diabetes, are really, really fat. So like, at some point, we do need to try and make the population healthier.
100%.
And that's where GLP-1s have apparently bridged this gap. But you made a comment the other day in terms of we focus too much on weight as opposed to underlying health in general. So why do we use weight as the indication? Why don't we use it as like a health jab, you said, or a health gain jab? And that could be a different way to look at it. So
I think in the media, it's called a weight loss jab, or it's called the skinny jab. The sole aim or the sole goal that you think about in that when you use that term is, I want to be slim, or I want to lose weight. Why can the media or us as health professionals say that it's a health gain jab? So instead of just a weight loss jab, you will lose weight because that will be a side effect, but the main aim for you wanting to be on this drug should be that you want to gain your health back. And I think if you think about it in that way, it forces you to sort of switch your mindset so that you may then try to make longer lasting change. But we are a long way off, but I think the only thing that we can do is just keep on advocating for preventative health, and hope that the NHS get on board with it and it gets better. So
say if I wanted to do, if I'm considering Ozempic or Mounjaro or something, a weight loss jab, a health improvement jab, if I'm considering that, but I don't necessarily want to do it, I want to do it a more natural way, what are the things I can be doing?
So we looked a lot into different things, and there is so much information out there. I think if you find one study on something and it says it's beneficial, you'll find another to say that the same thing is not beneficial. But from what we've gathered and what we've looked at, probably a mainly plant-based diet would be what we advocate for. So they say to eat about around 30 different plant species a week is good for your health. So I'd say that reducing your consumption of ultra-processed foods to 0 if you can.
30 different plant species per week?
Yes, sorry. Yeah. So that can be anything like fruits, vegetables, spices, herbs.
Yeah. And that's for the diversity of your gut microbiome as well?
Yeah. So that would be the first thing. Then I would say reduce your consumption of ultra-processed foods. So, like I say, to 0 if you can, but if not, just even reducing it by whatever you do tend to eat.
Yeah, somebody was mentioning like a 90-10 rule. Where it's like 90% of your food is a single ingredient. So like a carrot is a single ingredient. Like there's no crap in a carrot. It's just a carrot. Yeah. Hopefully.
Pesticides next.
Yeah, probably. Yeah. But if you're eating like apples, carrots, lettuce, chicken, they're all like single ingredients. Yep. So there's like this 90-10 split, whereas like you can have a bit of crap, but don't be having it all the time. Because I would say a lot of the people I know are eating food that's got like 40 ingredients in it, 3 meals a day.
Yeah. But try and do it. Try and actually look at having 100% non-processed. It is near enough impossible in the Western world.
Super hard.
I mean, the only thing that we have processed that I know of is oat milk of a morning.
Yeah.
In your diet?
Yeah.
In my diet, yeah. And yours as well.
Yeah.
I mean, Jess does all the cooking.
What about that protein bar you just had?
So I've actually not had protein now since November 23.
No shakes?
No.
No protein bars? Nothing?
No.
Lee's an incredible Nick, by the way, so it's clearly working.
But in terms of what should you do if you're not going on a GLP-1, I think it's changing your perception on what is healthy.
Yeah.
Because we always think of this bodybuilder with 4% body fat as realistic for men and women, and it's not, because we know that's not the pinnacle of health. And it should be. A lot of people, like you said earlier, are misusing these jabs. They've got a BMI of 26, so they're not technically licensed for it, but they're saying, oh yeah, I'm diabetic, and they put it on this private form. It just gets sent off to an online form, and that's it. You get given the medication. Yeah,
I think BMI also, though, isn't particularly helpful, is it?
It isn't.
Because my BMI is like 29.
Yes. Yeah.
But my body fat's 7%.
Yeah.
If you're looking at Eddie, he's like...
You had this issue, didn't you?
I did. But I do think BMI is a good population metric in terms of it gives you a good idea of...
Roughly.
Yeah, roughly.
But in terms of if I see a patient like you come in and your BMI is this, I don't use that. I use body fat distribution, visceral fat.
DEXA scans.
Yeah. And that's what it is. But I think as a general overall net, if you threw that on, I think the majority of the population who've got a higher BMI than what's healthy will be correlated to higher body fat percentage. But there will be people like yourself and whoever.
Rugby players and
who will fall outside of that.
Although that's another argument or another thing to discuss, because I always think about, I know that people who are bodybuilders tend to have lower body fat percentage, but you've still got you're still carrying a lot of extra weight on your skeleton. So is that healthy? It's obviously healthier than being obese, but you know what I mean? It brings up the...
I mean, they've absolutely destroyed the brain and testicles by the amount of steroids that they're taking.
But that's a good point. They've got to get there normally via unnatural routes.
Yeah.
So is there a point where the heart... I mean, if you've got a house and you've got a boiler, there's only so many extensions you can put on before the boiler goes, well, I can't do it. Even if you've insulated these extensions. Yeah.
So
that's
the pump's working way too hard. But that's why they're getting like left ventricular hypertrophy, and that's why they're getting heart failure. That's why like the MI rate goes up massively as well, because the heart's just like
and AF as well in young men. It's gone up massively.
I mean, pre-workout is, we done that last week, 300 milligrams in a serving, so they're having, again, all this with testosterone, all these other things. It's going to lead to all these complications.
Yeah, it's interesting, isn't it? I just think general advice should be eat as natural, low processed, highly nutritious foods with biodiversity as possible. Having some fermented foods as well will help with your gut microbiome, and consider, well, you've got to sleep well. The impacts of not sleeping well are huge. So have a really healthy sleep routine. Try and go to bed and wake up at the same time every day. Avoid alcohol at least 4 hours before bed. Don't eat a meal 3 hours before bed. Don't exercise 3 hours before bed. Like, allow yourself to like chill out and get into a good sleep. And then exercise, I think you've got to be covering the 5 domains, which is muscular endurance, muscular strength, flexibility, cardiovascular, and the final one is body composition. But that'll kind of come with all the other bits if you're nailing that. So I think generally, if you can eat like that, exercise, looking at those components, because some people will just do strength training.
Yeah.
And you know what it's like? The flexibility is terrible,
Yeah.
and they're starting to get like muscular issues on the back of that.
You can't walk upstairs without
Can't
being
walk
on
up the stairs and they're knackered, yeah. Or the flip side is you get the like ultra marathon runners, and they're getting other issues as well. You're seeing like football players as well who are doing so much cardio, they get like Hockham and things.
Yeah.
It's interesting, isn't it? But I think, as with all these things, it's balance.
It is.
It's about like a blended approach of flexibility, strength, endurance, cardiovascular, same in your diet. Have a blend of things, and then have a healthy sleep routine, and you will be so much healthier.
Yeah. That's the biggest
I
thing.
agree
sleep,
with all
isn't
that.
it?
Yeah.
Is there
And
anything,
stress management as well.
Yeah.
That's a good one.
is there anything else you want to go through on Ozempic? Anything we've missed?
Not that I can think of.
No.
Good.
Yeah.
Nice. We'll end it there. Thank you very much, chaps. That's been super helpful. If you do want to take any of these blood tests to find out the impact of your nutrition and where you find yourself, then feel free to contact us at health@thewellbeingdoctors.com, and we can build out a very specific blood test for your body. All of these come with a follow-up with the doctor as well. We will not test you without you speaking to a lifestyle-trained doctor, because we just think it's completely inappropriate otherwise. So make sure that you are tracking your health. Try and implement some of the things that we've talked about. It's super hard. It's really hard to change your behavior. But even if you can take one next healthy step, please try and incorporate that next step into your life. It might be the tiniest thing. It might be, I'm just going to drink one more glass of water a day. Whatever it is, just take one small step forward and try and not take any steps back. You're going to struggle. It's going to be hard, but keep plodding and you'll get there. We'll see you on the next episode.